It is my pleasure to present mitral valve repair challenges via percutaneous approach. My name is Chad Kliger. I am an associate professor of cardiology and cardiothoracic surgery at Hofstra School of Medicine and director of the Structural Heart and Valve Center at Lenox Hill Hospital, Northwell Health in New York City. As we all know, transcatheter mitral valve repair is indicated for both primary and secondary treatment for symptomatic mitral regurgitation. There are features on echocardiography that are ideal for leaflet plication, those that are challenging, and those that are relative contraindications that involve the location of leaflet pathology, the calcification, mitral valve areas and gradients, grasping zone length, the degree of coaptation length, flail width and flail gaps, as well as other pathology that include annuloplasty rings and other. We need to know our technology. This includes MitraClip NTR, the traditional clip, the MitraClip XTR, which has longer arms for easier grasp and better reach, the novel PASCAL clasping device, which has a central spacer to fill regurgitant orifice and reduce leaflet stress, as well as independent leaflet capture. There are anatomical situations that will favor an XTR over an NTR device, with an NTR device favored in patients with short restricted leaflets, calcified annuli or leaflets, smaller mitral valve area, and Commisural mitral regurgitation. As we go through our Class 2D2F trials and look at the newer generation 4 of MitraClip, we'll better understand what their roles are in this complex leaflet and anatomic pathology. Large flail gaps can be measured in two views. Greater than 10 millimeters may require adjunctive measures, which can include grasping a clip just adjacent to the large flail gap, the application of adenosine to cause cardiac asystole for the leaflet to lay within the arms of the clip or clasping device for leaflet grab. Independent leaflet grasping may be an additive tool where we have the ability to fine-tune leaflet position in relation to the device and redirect from the anterior leaflet, which is grabbed above, to the posterior leaflet for leaflet optimization. You have to be aware patients with stiff leaflets, extensive MAC, and borderline orifice areas, as shown here, which may require one single NTR clip for a good result, or consideration of a PASCAL device with a PASCAL spacer to prevent significant reduction in mitral valve area. If patients have mitral valve areas that are less than 4 centimeters squared on transthoracic or transesophageal echo, we need to take into account a patient's BSA, degree of MAC, as well as the mobility of the leaflets. It's important to look at alternative imaging. This is just one example of a 4D CTA that can identify extensive MAC. And you can also clearly see and planimeter the mitral valve for consideration. Commisural mitral regurgitation can be a challenge. And the use of one single NTR clip in the lateral medial location can be utilized, in addition to the potential rare reported cases of a placement of an ABP2 device just adjacent to the clip to seal further additional regurgitation. Patients with cleft posterior leaflets, the use of convergent clips or clasping devices has been reported back in 2016 and can be utilized for patients of prohibitive risk for valve repair replacement surgically. Is one repair technology enough? You can see here a patient with significant mitral regurgitation after one clip, still significant residual regurgitation with multiple jets, and after the placement of a transcatheter, another repair technology, an annuloplasty ring of the cardioband, you get a result that's very similar to a standard surgical Alfieri stitch, which includes an annuloplasty ring. We know that failed surgical repair, as shown here, can be treated with clips or clasping devices to mimic a surgical approach. May be more difficult to visualize in patients with complete rings due to shadowing on the anterior mitral leaflet. And finally, repair of a surgical mitral prosthesis with a paravalvular leak. This is a scenario where in a patient that had a severe medial located between 1 to 3 o'clock PVL and central leak, despite multiple attempts via transseptal approach to cross this paravalvular leak with 2 transseptal punctures and multiple adjunctive techniques. We must not forget a transapical approach, alternative access. So in this scenario, percutaneous transapical approach was utilized via fusion imaging, gaining a 6 French sheath access into the left ventricle. We were then able to cross this medial leak location, rail a wire from the transseptal to the transapical access, with plugging of the PVL with a 10 millimeter AVP2 device and mitral valve and valve with a sapient enclosure of the apex of the heart within another AVP2 device. In addition to device technologies and leaflet anatomy challenges, patients can have excessive risk for general anesthesia or contraindications for TEE. Alternative modality must be considered. In this case, the use of a 4D IntraCardiac echo can be utilized to obtain imaging that's sufficient for clip or clasp implantation. We can utilize imaging even further with TEE-Fluoro fusion imaging, which allows us to overlay models of the left atrium and the mitral apparatus directly onto our X-ray image to deploy repair technologies, as can be identified here, with reduction in steering time and reduction in fluoro time and radiation dose. CT fluoro fusion imaging can identify mitral annulus. This can be overlaid directly onto X-ray to allow us to implant a cardioband device with the anchors placed on the mitral annulus away from the coronary arteries. We can then also, with newer technologies, change the basal imaging modality, overlay CT directly onto echo, and utilizing multimodality fusion imaging, overlaying CT and echo directly onto X-ray for complex interventions. We do know that current technologies allow us to diagnose, plan, and guide with fusion imaging our complex cases. The hope is that in the future, we'll be able to better see these mitral valves and valve images to then do patient-specific biomechanical mitral valve models, computational blood flow analysis, and provide a personalized therapeutic plan that involves either single or multiple technologies with a very predictable outcome. To conclude, challenges exist with percutaneous mitral valve repair that can be related either to patient and/or anatomical factors. Limitations of technology, both device and imaging, can occur, and we need to develop strategies to optimize our current technologies. When single repair technologies is insufficient, this may require a combination of technologies. Alternative approaches, replacement instead of repair versus one repair fails, a replacement bailout will be necessary. Finally, complex TMVRe repair is nothing without imaging. 3D, 4D echocardiography, TE, and 4D ICE, in addition to fusion imaging, makes success in these challenging cases essential. Thank you very much, and stay safe.